Good afternoon. Welcome to another edition of McMaster Perspective. I have a pleasure of talking to our section editor of infectious diseases and prolific author of papers on infectious diseases and especially influenza and lung diseases, Professor Mark Loeb from McMaster University. Professor Loeb will be talking today about pneumonia. And the impetus for this was coming, let me share my screen, from a particular trial, from a particular practice guidelines published by American Thoracic Society. And it talks about diagnosis and management of community-acquired pneumonia. I believe that before we started, it may be worthwhile to introduce some vocabulary which was used and some definitions which were used in this guidelines. The guidelines provide recommendations depending on severity of community-acquired pneumonia, and that may be relevant to go over what they considered as the reason to classify something as severe pneumonia. There are major criteria, which is no-brainer: septic shock with need for vasopressor and respiratory failure requiring mechanical ventilation, obviously in the presence of clinical syndrome consistent with pneumonia with radiological or ultrasound evidence of infiltrate. But there are also minor criteria, and according to them, you need 3 or more of such criteria. They are listed as respiratory rate, which is rapid, high level of oxygen requirement, multilobar infiltrates, confusion, disorientation, but also leukopenia, thrombocytopenia, hypothermia, or massive fluid resuscitation. Compare it with severity, which exists at the moment in our McMaster textbook of medicine. It's really similarly, nobody will question septic shock and respiratory failure. There is confusion, respiratory rate, low blood pressure, and age over 65 as severity. Obviously, those criteria overlap, interact with each other, but generally provide at least some guidance for clinicians. The other thing which they differentiate their recommendations according to are presence of comorbidities. And I would like to stress here that there are 15 people on the panel, and essentially they were saying this is comorbidity or this is not, and they were trying to agree with each other. So chronic pulmonary diseases other than asthma, 82%, probably 11 or 12 out of 15 said, yeah, this would be a comorbidity. End-stage liver, end-stage renal disease, alcoholism, neoplastic disease, cardiovascular disease, 53%, but I suspect they all had something different in mind. And less than 50% of them were considering other diseases as comorbidities. What I'm stressing here is that there is no exact science here. There is a gestalt, there is an impression of people who classifies as a person at higher risks of complications. And lastly, they are also talking about duration of treatment using definition of clinical stability. So they are saying if the patient is stable, you could use less than whatever number of days. And I think it may be relevant to put the criteria for stability, which is essentially a febrile person who is not tachycardic, who is not breathing too fast, who is not any longer hypoxic, who has respectable blood pressure, although I would say if your normal is 140, being 95 is a little scary, and normal mental status. So after going through those definitions, again, what is clinically stable, what is comorbidity, how do we define severity? Let's go, Professor Loeb, I will stop sharing my screen, and the floor is yours. What did you, as infectious disease specialist, what are your impressions or conclusions from these guidelines?
Well, my main conclusion is that, and we'll talk about the other, recommendations, previous recommendations, is that more or less they're the same. As you've outlined, there are clearly gaps in terms of, for example, outpatient comorbidities. There's certainly gaps in the literature, but most of the recommendations, basically carry forward. The real change, or I'd say one where there is controversy, and that's between the Infectious Disease Society and the ATS, is with respect to individuals who have a comorbidity and have a virus detected. And we're not talking about SARS-CoV-2 or COVID-19. We're talking about things like influenza, parainfluenza, or adenovirus, because the ATS guidelines for those patients who have, again, outpatient comorbidity, who have a virus detected, they recommend empiric antibacterial therapy. And they also recommend empiric antibacterial therapy for patients who are admitted to hospital, but who are not severely ill, who have one of these viruses detected. So the controversy is that the Infectious Disease Society does not believe that those two groups of patients should be treated empirically, and empirically means without any more microbiologic diagnosis. They feel that the evidence is not there to substantiate that. And the American Thoracic Society guideline reviewers, that they sort of admit that the evidence to treat is not really there, but they felt that the potential for harm is there. And on the other hand, the Infectious Disease Society clinicians feel that, well, the evidence to treat is not there, but the evidence for harm of potentially unnecessary antibiotics is there. So that's the real controversy.
So let me make sure I understand it. We have a clinical syndrome of pneumonia. We are not talking about the patient who is confirmed or strongly suspected of bacterial pneumonia, but we have a patient who has clinical syndrome, tested for viruses, the viruses come positive. The presumption is that it is a viral pneumonia, but one society says we cannot rule out bacterial superinfection or co-infection, and the other one is saying we may not be able to rule it out, but the evidence for using antibacterial in this situation is either non-existent or low, and probability of harm is there, so we do not want to treat empirically, correct?
That's correct, but it's very important to point out that both societies agree that this does not apply to severely ill patients. So a patient who is admitted, and let's say to hospital and is going to the ICU, both groups agree that if they have a virus detected, they should be treated with an antibacterial empirically.
In addition, okay. So in this case, it really doesn't talk about choice of antimicrobials for those people or antibacterials, but it simply say, if you're severely ill, even if your virus is detected, even if you suspect it's a virus, you still go with antibacterial treatment. And maybe a question here, Professor Loeb. If the virus is detected outside of COVID, which we leave aside here, any antiviral medications which we should routinely consider?
Well, oseltamivir would be an antiviral for influenza. So if influenza is detected, that should be considered. Usually it's administered to people who are at least pretty sick, who are admitted to hospital. So there's an element of severity of illness there. And that's what we usually do in practice.
No para-influenza, just influenza?
Just influenza. Oseltamivir only works for influenza.
Okay, now the groups of recommendations which were there were first whether one can use ultrasound to substitute for an X-ray or CAT scan or whatever is being done in a given stage. And I believe the suggestion at least is that it could be, providing that there is some expertise in interpretation. Maybe I will go to the last recommendations, which dealt with use of steroids in pneumonia. What's your interpretation, especially there could be COVID, there could be influenza, I mean or there could be bacterial infection. How would you see that?
Yeah, so there certainly was concern for patients who are, moderately, mild to moderately ill, not to use steroids. But for those individuals who are severely ill, the recommendation was to use it because the benefit would potentially outweigh the risks. That was that was the basic gist of the recommendations.
Okay, something crosses my mind about use of steroids in patients with influenza pneumonia. Do you have any opinion here?
The systematic reviews that have looked at use of steroids have been really for community-acquired pneumonia, presumed bacterial pneumonia. I'm not aware of any studies that have looked at specifically for influenza alone, influenza-related pneumonia alone, that is.
So if we had a person with severe influenza pneumonia in the intensive care unit, are you prepared to give suggestion or recommendation for steroid use, or not at this moment?
Well, again, based on the ATS guidelines, if there's someone who's very severe, and let's say influenza was detected, antibacterials would be used as well, because there's the potential that there is a superimposed bacterial infection, and this superimposition of a bacterial infection on top of influenza is very well described. Right, there are different mechanisms, destruction of the epithelium. There's about 5 different mechanisms. So I don't know that someone would be, that would be incorrect to do that. But again, I guess it's certainly a gray area.
Not a science exactly. Another area in which these guidelines touched upon quite a bit actually is duration of treatment. Duration of treatment in patients who achieve stability obviously may be different. And I believe we just completed an ICU study which looked at 14 versus 7 days. Here, the guidelines seems to be even more aggressive in terms of shortening. Could you comment on that?
Yeah, so the study you're referring to, I believe, was for a bacteremia,
Bacteremia, that's correct.
So this is a bit different. So because it's pneumonia, not necessarily with a bacteremia, and the cutoff has been about 5 days, right? Whether to use more, at least 5 days, or more than 5 days, or less. And the guidelines really suggest that for those individuals who have severe pneumonia, you should go at least 5 days, if not more. For those with mild or moderate pneumonia, less than 5 days.
Especially if they achieved stability.
Right.
Professor Loeb, I would like to finish with something what these guidelines did not necessarily addressed, which is choice of antibiotics. I would like for that, if you don't mind, to again share my screen and bring the excerpt from our textbook, which it tries to, in simple way, describe empiric treatment. Obviously, it is not when you have the pathogen. Could you comment if it's still valid, at least from Canadian perspective?
Yeah, so if you look at the IDSA, ATS guidelines, these recommendations are compatible with that. But more recently, there have been Canadian guidelines that are, as we speak, are being developed. And one of those recommendations for individuals with mild to moderate pneumonia will be amoxicillin for those individuals. So that would be 1 gram of amoxicillin orally 3 times a day.
And is macrolide or doxycycline, are those acceptable options? No, not sure which one you would consider preferred. It sounds like amoxil, but are the others one acceptable?
Yeah, the first choice is amoxicillin, but for individuals who might have a potential allergy, azithromycin or doxycycline or clarithromycin are possibilities.
All right. Now I'm looking at the people who are still outpatient but have higher risks, either are older or have chronic, whatever it means, comorbidities which put them at increased risk. I see here that we are recommending respiratory fluoroquinolone or beta-lactam and macrolide. Still acceptable?
Um, that again, it's within the IDSA ATS guidelines, those certainly are acceptable. Within the new Canadian guidelines, we just discussed the mild to moderate. Um, other than that, it's really severe pneumonia, and for those individuals, it would be something like either cefotaxime or ceftriaxone combined with clarithromycin or azithromycin. Other possibilities include a respiratory fluoroquinolone like levofloxacin or moxifloxacin.
Okay. And when we are talking about beta-lactam antibiotics, are we still talking about beta-lactam as amoxil or amoxyl clavulinic acid or some cephalosporins? I'm talking here about this medium category, so to speak, somewhere between amoxil and heavy beta-lactam with macrolide or
Yeah,
fluoroquinolone.
yeah. The beta-lactam and macrolide, the beta-lactam here usually refers to a third generation cephalosporin.
Okay, and here in this, still possibly, would you consider cephalosporins or something different than amoxil in the
No,
treatment of outpatient?
yeah, the amoxicillin is, that'll be likely mainly mild to moderate individuals. So that would be mainly outpatients. So yeah, so sometimes it really is dependent on the definition of severity. But the Canadian
Right.
guidelines, again, mild to moderate is amoxicillin. Severe is this combination of a beta-lactam and a macrolide or a respiratory fluoroquinolone. So it just sort of simplifies this, and the
Right.
Canadian guidelines are based on the World Health Organization guidelines.
Right. Well, it sounds to me that we at some stage may want to update this chapter and even simplify it further. I believe that at the moment it still provides reasonable guidelines. We also talk about use of steroid in severe pneumonia, just to complete the dosing, anywhere from 40 to 50 milligram prednisone equivalent per day is what we have found. And let's hope that we will not get too many patients together with severe pneumonia.
Let's hope so.
Professor Loeb, thank you very much. Really appreciate this update. Thank you.
Thank you.